so that way they didn't have to deal with all the rest of our logistics and such. So for today, thank you so much for coming. Welcome to First Do Nothing, when restraint is the most responsible care, and this is an educational event hosted by El Paso County Medical Society. This evening we have our moderator, Dr. Margaret McDonald. We also have our panelists, Dr. Robert Lamb, Dr. Jesel Patel, Dr. Royce Topol, and Dr. Valerie Beck. We are very grateful for our physician members who are contributing their expertise this evening. And we are going to turn it over to Dr. McDonald, and she's going to moderate our event.
Okay, so I need to use the little pen, huh? Okay, hello everyone. Thank you so much for joining us tonight. And we're going to have an interesting discussion. And I think what I'll do is just really quick by way of introduction is remind us what are the objectives from our discussion this evening. This is a CME event. And so we're hoping that you will easily at the end of the evening be able to differentiate clinical scenarios in which watchful waiting or non-intervention is evidence-based and appropriate across pediatric, emergency, family medicine, and neurologic care. And you will also be able to identify strategies for communicating non-intervention decisions to patients and families in high anxiety or high expectation situations while maintaining trust and shared decision-making, and recognize system level and cognitive pressures that contribute to over-intervention and apply clinical judgment frameworks to mitigate unnecessary testing and treatment. So I'm going to begin by letting our panel introduce themselves. So if we could just have each of you take about 1 minute and just, say your name and your specialty and just talk very briefly on how your practice setting is perhaps very appropriate to this topic about possibly doing nothing being the most appropriate intervention. So we have a couple of these pen microphones on the table. I'm going to pass mine over to Dr. Beck.
I think the microphone's for the recording, so I'll talk loudly. I'm Valerie Beck, pediatrician. I work with Sunrise Pediatrics, or at Sunrise Pediatrics, which is a 2-3 person practice, so very small practice, North Springs, so just off of I-25, kind of at Chick-fil-A area. Yeah, so I guess do nothing, or watchful waiting, or just deciding to do nothing. The first thing that comes to mind for me and has been kind of there for my whole practice is antibiotic use and using antibiotics, judicious use of antibiotics, not using them when they're not needed, and trying to follow some criteria, I guess, for use and not use of antibiotics. So that, I think, is a big part of my everyday.
And I'm Royce Topol. I work in primary care for UC Health at the Interquest location up north. And I think, a lot of primary care is prevention focused. And so trying to prevent things before they happen. And sometimes that's talking to patients about expectations and ways they can manage things themselves. And to a lot of patients, lifestyle changes is probably feels like doing nothing, but that's kind of what we try to push. So for the preventive care, and then also just cost savings for the healthcare system, hopefully is kind of, I think, the way that a lot of us are trained now, that something primary care takes to heart as well.
I'm Rob Lamb. I'm an emergency physician. I work for Emergency Medicine Specialist PC. We staff all the emergency departments in the UC Health system in the South here. So I thought this topic was super interesting. On the one hand, I have the benefit that most emergencies tend to declare themselves with time. So there's definitely a role for that. But at the same time, we have the momentum aspect of things too. So kind of balancing both the momentum of the time pressures that we're under, the ability to do a lot of stuff that may have downside consequences, with kind of a thoughtful, wise approach to using restraint. I thought was a really interesting topic. So.
I am Jesel Patel. I'm a medical oncologist. I work with a practice called Rocky Mountain Cancer Centers. We have about 50 physicians across the state, but locally we have 10, and we have offices at Penrose Hospital, or on the Penrose campus and St. Francis campus. I've been in practice for 11 years now. I think medical oncology is quite pertinent to this topic. A lot of the treatments we offer have very significant toxicities, which can potentially be long term. So, you know, in my daily practice, I mean, I have, you know, daily we have conversations about, you know, when to appropriately use the treatments and, you know, when not to. And, you know, we have a lot of quality of life versus quantity of life and, you know, when actually to intervene conversations.
Thank you all very much. All right, so that's a little introduction. So we have almost an hour for our discussion, and we have approximately 5 main questions that we're going to be covering. And I tried to combine some of these so that we would cover all the bases. So let's start with, and we can each of you can easily take a couple of minutes for these, 2 or 3 minutes, and this section is really about the clinical art of restraint and when intervention might create more harm than good. And so maybe we'll just ask each of you if you could think of a case that you've had experience with where doing more testing or treatment would have worsened the outcome or did worsen the outcome. It could be theoretical or it could be real. And in that context, thinking about sort of how were you able to personally recognize that moment when restraint was probably the higher skilled choice. And we are going to cover more in another question about how to navigate that choice in terms of the kinds of discussions with the patients, et cetera. So for now, if you could each just think of a case that would really illustrate this point, and whoever wants to go first, just let me know.
I go more less than a case and more than just a particular diagnosis. In hematology, oncology, and one of the common things we deal with are low-grade lymphomas. Particularly the most common one is CLL, chronic lymphocytic leukemia. And, you know, the typical presentation with that is somebody goes in for, you know, a routine blood test, or, you know, they're ill in the ER and it's the first time they've seen a doctor in a long time and their white count, you know, is 100,000, which oftentimes is, you know, very alarming, you know, when you see that number. And, you know, when patients see us and, you know, we make that diagnosis of CLL, I mean, you know, most of the time, you know, people are pretty anxious about the diagnosis and, you know, kind of the reflexes or when we're going to start treatment, when we're going to do something. The diagnosis itself, you know, is a very low grade lymphoma, and often patients don't develop any clinical consequence or any, you know, clinical issues from the actual diagnosis for years, you know, from time of diagnosis. So, you know, in those situations, you know, we typically wait and just kind of follow along until, you know, patients develop symptoms. Symptoms typically can be night sweats, fevers, or bone marrow compromise. But the white count itself, you know, usually it doesn't hurt you, right? So when people see that number, they react to it, but we have to put in the clinical context. Well, the white, you know, the elevated white blood cell count itself isn't going to hurt you. What we wait for is, you know, for you, one, either to develop symptoms, or two, see compromise in the bone marrow, which is measured by low blood counts with the hemoglobin or platelets, or if patients get, you know, part of the disease, sometimes patients can get progressive lymphadenopathy that actually causes symptoms, you know, such as pain or, you know, I guess compression of other structures. And that could be hard to explain to people. You know, the reason restraint is good in that situation, you know, CLL, for one, you know, there's only a certain amount of treatments that we have, and you don't want to use up all those treatments early and just react, you know, at the time of diagnosis and treat. And even, you know, when patients are on treatment and it's working, then you stop treatment and they start to progress again. Sometimes, you know, patients will want to react and, you know, immediately go to treatment. But in that situation, again, you don't want to use up all your lines of treatment early, because down the road you won't have, you know, anything left to use. And, you know, nowadays, most patients with CLL, I mean, they live normal lifespans. It's very rare that we see patients pass away from it. So it's, you know, turned into a very chronic, manageable disease.
Mm-hmm.
Next.
Wow.
I remember early in my career, I saw a patient that came to by the ambulance, and he was clearly confused, and he clearly was working really hard to breathe. So I was straight out of residency, fresh faced, and I went ahead and got him intubated, sedated. Thought I did a really good job. But then his actual primary care doctor showed up at the emergency room. He's like, "Why did you do that?" I'm like, "Well, he was, you know, confused and you know, and he was having trouble breathing." And he's like, "That's a hospice patient. Why did you do that?" And so I think for me, so you know, so we got together and we extubated him. But for me, it was a valuable lesson that when I I never thought I would have those discussions in the emergency department, but end of life care, but I have them more and more. And then when sometimes if we overact and do too much for the patient, particularly at the end of life, what we're robbing them of a good death. So I've learned a lot about starting to have those goals of care discussions in the emergency department, which I was never trained on in residency, but has definitely become part of my practice. So.
And yeah, I mean, for me in primary care, we see, I mean, patients for pretty much anything that they want to come in for. And so a lot of times we see, abdominal pain, and it may be subacute, and we'll get, a scan or a CT scan or something like that. And then, they'll find a cyst in their kidney or a cyst in their liver. And then, we really won't find any other cause for their abdominal pain, but they'll have this incidentaloma, like we usually say too. And then that'll lead to, radiology says, well, it's got some features of this lesion in the liver, and maybe you should get an MRI of the abdomen, and it kind of leads to kind of more testing for these things that are benign, that maybe if there were other things. Like I have a lot of patients that diet is pretty poor. A lot of patients are eating mostly processed foods now, and talking to them about healthy diet changes. A lot of that does help a lot of patients with a lot of their kind of general chronic abdominal pain symptoms most of the time too, that can be helpful. It can prevent like exposure to radiation, exposure to more testing, and then potentially those invasive tests that can get done depending on what's found in some of the imaging too. But definitely one case that sticks out for me too, just in particular, is during residency. I was on general surgery residency. Again, I'm not a surgeon, I'm just primary care, but we had a patient who was in the psych ward at Memorial Central, and she had swallowed a thumbtack from her room. And so I was on general surgery team, and they wanted me to go to kind of ground rounds for this patient to kind of figure out what to do. And that was kind of cool to see, because they were kind of relying on me for, well, are we going to take her to surgery or not? And I said, well, I think we just watch and wait, and if she passes it, then great, and if not, then the answer is pretty easy, then she goes to surgery. And so she passed it, and she did fine, and it was good. So
Small world, HIPAA. Yeah, so along the antibiotic sort of overuse topic, I was in practice when I first finished residency in Middle Tennessee, and I worked with generation above me, other pediatricians, and in a family practice group, and I encountered just so many kids put on antibiotics for purulent rhinitis, sinusitis, that kind of thing. And so I guess the one case that sticks out in my head, and it wasn't like an individual bad outcome, because the overuse of antibiotics is more like a countrywide resistance problem. But the about two-year-old had like literally like one every month a course of antibiotics for those like non-specific diagnoses. So that was difficult, and we're going to talk more about it, but it's difficult also because the families and the patients expect that's going to be your answer to like every virus that they get. So that made like entering practice hard. And as I like got new babies and stuff, it was easier for me because I was more using, I guess, judicious antibiotic use. And then more recently, I had a patient that she's like preteen, and was having like dyspnea on exertion, which isn't usual for kids unless they're asthmatic, and she had asthma, but the pulmonologist was saying I don't know if this is asthma, and she couldn't lie flat, which also is not usually a kid thing. And so kind of looking into it, she ended up having like several anomalies. She had like an interrupted IVC, and the azygos vein was very large and went into the atrium. She had an aberrant left subclavian artery, so it was going behind the esophagus. She also had problems swallowing, like dysphagia and such. And she had a little bit of malrotation of her gut. And so people were very conservative about doing surgery on any of these things. And it was like reaching from pediatrics into adult medicine and stuff. And like, what is that, what is the aberrant subclavian doing? Is it really compressing her esophagus? Is it compressing it enough? That kind of thing. And the family wanted a second opinion. So they ended up getting a second opinion out of town. And they were very conservative as well. They fixed the malrotation, but not the other anomalies. And along the way, like some of the x-rays would say like there's a significant scoliosis, but she hadn't had a well visit. And And in retrospect, I should have done something about that before, but she had her well visit. I'm like, whoa, your spine is really curved. And so she got placed in a brace, and many of her symptoms are like, she's better now. So I don't know, there was a lot of sort of maternal worry and angst within that as well. I think that that maybe made her symptoms kind of bigger than they were, but that was true watchful waiting. And a couple of surgeons, saying like, I don't think this is what's causing her symptoms, and not operating, doing kind of big operations she didn't have.
Wow, thank you all. That's amazing. So in that case, they could have dove in and done like 16 surgeries, but some of the answers were reasonably simple.
Right.
And abdominal pain, of course, is that great, vast bugaboo for all of us, right? It could be so many things. And if you don't even have the chance to ask them what they're eating, yeah, it could be as simple as that. And I was a little bit surprised about the end of life care thing in terms of you not having had too much exposure to it before. Just too bad. But yeah, that is a big thing. I think you're right. At the end of life, we don't think about that. And we don't always need to do everything. And the other example of that, I guess, would be things like prostate cancer in an 85-year-old. Same kind of idea, right? You don't necessarily have to dive in and do stuff. So you surprised me, because I'd forgotten about things like CLL and how, we were all going to think that the oncologist was all about treatment all the time. But in fact, you're not. And that's good to hear. Okay, so thank you. So the next sort of theme to get into is about, doing this differentiating between watchful waiting versus, neglect, I guess, versus not even really wanting to think about it, or perhaps not taking it seriously enough. Because the watchful waiting isn't just saying, oh, this is not so serious. It's that you are looking for what happens next in order to decide what is necessary, right? And so we want to talk a little bit, if we can, about, how do you really distinguish this sort of evidence-based observation from what might otherwise be perhaps risky delay, and how do you kind of feel comfortable with that decision? And when you have to talk to the patient about that, that can sometimes be tricky, I'm sure, to be able to have them agree with you or to feel as if that is the best way to go. So I'm sure you probably also have case examples of that. If you want to use those, that's fine, or just simply share your thoughts. I know sometimes it has to do with making sure red flags aren't there or alarm symptoms, et cetera. But mostly, yeah, let's talk about really how do you navigate that decision, especially then how do you convey that with the patient or perhaps the patient's parents?
I can go first. Yeah, I think this is a hard one just because we live in a society now that's so like procedure focused. Like people want to get that joint replacement, they want to get that injection in their back, and they want to kind of have things done to them. Sometimes it feels too, and then there's certainly like another population that is certainly avoiding intervention too, when when it's appropriate. Yeah, I mean, I usually use kind of like close follow-up as a tactic too. So like viral infections are kind of the big example for us in like outpatient primary care too, is, patients come in and they've been sick for 3 days with runny nose, cough, and fever. And they're like, I can't handle it anymore. Like I need something now to feel better, and, kind of reassuring them that things are going to take time. And I'm like, listen, like this is the timeline that we expect you're going to be sick for. Like if you're not better by this point, like come back, let me know, we'll talk about it. And so, I usually try to temper it that way with close follow-up and having that too. And sometimes leaning on support staff if you have, those other options like in your clinic. So like a nurse or an MA, I mean, really kind of helping them to work at the top of their license, having a patient come back, check in with them. And if they're doing better and just kind of telling them they're better, then they can go about their day. But if not, then they can pull you in and kind of see them again too with that.
Down here. Yeah, I along those lines, I guess I like algorithms. I think some people don't always like algorithms or don't agree with algorithms, but I think you can take each one individually and decide this one's good, it's not, kind of thing. But I just like that somebody's really thought about it and thought about the pathway and has it like just set there so you can kind of follow those steps to a degree. and then things are put in words. I think there's a lot of art to medicine, and that's good. And I think over time you get experience and you feel more comfortable with kind of what you're doing based on your experience and what you've seen already. But I think it's good to have something written down that says, like, if this, and then you can reference that too with the patients. For example, with antibiotics, like we try not to use antibiotics with a viral upper respiratory infection for 10 to 14 days, and this is written and this is how we do it. And people get used to that. And then again, like talking with the families and spending the time like with sort of what the natural history of this disease is, or, mucus turns yellow, then it turns green, then it turns yellow, then it turns clear, and it's all viral, or, it's really hard to diagnose sinusitis. CT scans, you might line up a bunch of kids, get them a CT scan, and, certain percentage of them are going to have full sinuses from their cold or just because kind of thing. And we don't really know it's bacterial and all that kind of thing. So I guess just like talking and explaining, I think parents appreciate that. So often that works.
So I think you made reference to a number of good things. So I think most of us in emergency medicine love algorithms.
Yeah.
We love algorithms. We like to follow the algorithm. And I think that just points to, in some ways, that we feel there's more security when we're all kind of practicing the same way. And I think that the game changer for me in my practice has been medical decision-making rules. So I don't think they replace a physician's gestalt, but they are very helpful. So when I think about PCARN for head trauma, we used to just kind of look at kids and say, well, I don't know, maybe you're sick, maybe you're not sick. PCARN is so helpful because I can actually give patients and their families percentages. Like, this is the risk of a significant head injury. And then I think, for the observation, like if your kid is normal in 24 hours, they approach 0%. Like, that's as good as clinical medicine gets.
Right.
So having a medical decision making, having a culture where we're kind of practicing the same way, I think kind of keeps us all safe.
Yeah, no, I definitely agree with that. For oncology, we have guidelines, something called the NCCN, National Comprehensive Cancer Network Guidelines, that kind of have, algorithms and flow charts on how to approach, cancer and even follow up. One of the, very common, difficult conversation I have with patients often is after they've undergone curative treatment. For example, breast cancer, when women go through, breast cancer, first step is typically surgery, whether it's lumpectomy, mastectomy, that's often followed with radiation and chemotherapy. And a common question I get, afterwards is, well, what are we going to do to make sure my cancer does not come back? And, the reality, most, stage 1, stage 2 breast cancers, the chance that, something comes back, down the road is less than 10%. And a common question or a common request I get is, well, can we do a PET scan every 2 or 3 months just to make sure it's not coming back? And, I frame it, guidelines clearly say do not do that unless there's, clinical suspicion of recurrence. So I often frame it too as, if we, I give them the percentages and I say, if we scanned every woman who had breast cancer every couple months, I mean, overall, the amount of scans you would do, you probably would cause somebody down the road and increase their risk of getting cancer. And they seem to respond to that when you explain it like that. And the other way I kind of approach that is, we have a very low threshold. One, we don't do it routinely just because, but we do constant follow-ups every 3 to 6 months after somebody's finished their treatment. And, we have a low bar to do it. I mean, if there are, symptoms that are suspicious, we react to that and do the appropriate testing. And, that reassurance that we will, if we need to, is very, very helpful.
Yeah, I like that with the algorithms and, aids for medical decision making. 2 little points I just want to sort of help share here. One is you mentioned about talking to the patient, explaining the timeline that's expected and why the symptoms are happening and the resolution, and spending time. And, I guess we could also argue that in itself is therapeutic. And so it's not really doing nothing, right? Which is right. The other thing is, you all mentioned sort of a serious situation or more acute situations, but there's also those sort of longer term situations. Like, for example, Dr. Tovel, maybe you'll speak to this, someone who with a high cholesterol, like at what point do you decide to put them on statins? Maybe we have the risk calculators. but there's going to be a time when you feel like, well, that's not necessary yet. So do you want to speak to something like that for a moment?
Yeah, I mean, I do think the cholesterol is a good example too, and I think statins have been in the news recently, and so a lot of patients are kind of coming with their own knowledge about that too, and kind of some research regarding that too, and so it is hard to explain that too, and especially now, I think there's like explaining to patients, like for me, they don't necessarily need to fast for a cholesterol panel anymore, because if I'm using the calculator, then the two numbers that I'm going to get really are not impacted by fasting, but I kind of leave that up to them too, and then we'll kind of calculate that, and I'll show it to them together, and I'll pull up the calculator, and I'll say, here's your estimated risk of heart attack or stroke in the next 10 years. And, we think that having a risk below 7.5% is acceptable to some, right? And below and above that is not. And so, according to this, we'd recommend that we put you on statin. But I usually go like further than that, because patients don't really respond to that hard, like number data all the time too. And so CT calcium scores are becoming like a big thing now too, to kind of help make the decision, but that's another intervention that's exposing people to radiation too. And so I just try to say, like, you're 50 years old or something, like you probably have some plaque built up in your arteries right now. Like, your number is what it is, but the medication's also, potentially going to stabilize any plaque you have built up to prevent, an event in the future too. But a lot of patients still, and then I had some patients that are really resistant to taking medication. Their risk is super high, and then we end up getting that CT calcium score, and that does kind of help make the decision sometimes too. But kind of explaining that, they probably have some plaque buildup currently, and we're thinking about down the line kind of stabilizing that plaque as they get older, tends to help a little bit more too.
Right. Dr. Lim?
I'm good.
Yeah, okay. Yeah, so those sort of thresholds for when to intervene can vary too, right? Depending on the circumstances. Thank you. Okay, so then here's something that you've sort of referred to a little bit already about, when fear is driving the demand for action in some respect, right? So managing the patient and the family expectations, especially in high anxiety patients. And sometimes it's a matter of a dire situation, perhaps in the ER with an acute problem. Maybe it's an emotionally charged situation where someone's just really, really worried about what's going on with their loved one or with themselves. How do you handle that? How do you kind of slow things down and get back into the logical decision making? And this is not exactly the same question, but I'm gonna give you a couple of things, and each of you can speak to whichever one you wish. Also, then some patients, of course, as you mentioned, they've seen something in the news, or they've seen something on Dr. Google, and they come with certain expectations. And so how do we really manage those expectations, especially when they do clash with our evidence-based practice? And then spending the time with the patient is therapeutic, but sometimes reassurance alone feels insufficient to the patient. So again, perhaps you want to draw on some experience with cases and talk about sort of expectation management, basically. And sometimes you may even want to think about how it was tough, but maybe at the next visit, you then were able to continue to navigate the situation with the patient. So thoughts?
I'll go first.
Okay.
I just wanted to kind of address that. I think that the watchful waiting and doing nothing only works when you have a trusting relationship with the patient. And that's really hard to accomplish when there's a high level of anxiety or there's a emotional state going on in the room. So I have the privilege of facilitating a excellence communication course, and I'll just give a quick primer of what I believe in, because I live it every day. So like when I go into the room, the first thing I have to do is I have to make that patient and family feel like they're the most important thing in the world right now. I got nothing else to pull me out of the room. So I start with that presence. And then I usually try to call out whatever emotion I'm seeing. Like, it sounds like there's a lot of anxiety about this or that, or it sounds like you're really angry about this or that. And then we have that tool connecting with the pearls. So partnership, apology, empathy, all those little aspects that, and legitimization. So trying to connect with them on an emotional level so that they're on their side. And I think that really helps to kind of diffuse that emotional tone. But I only think that this works when the patient actually trusts you. Otherwise, I think you're doomed to fail. So.
say that it's different in ER medicine than in primary care, because you really have to gain the trust of the family or the parents quickly. And those things, that sounds like a good program, or right? I hadn't heard it before. But yeah, with parents and kids, early on, I had a family find me, and it wasn't so much watchful waiting, but they were unsure of what had happened in the clinic, and I was on medical leave, and they talked the hospital operator into calling me at home. And my mom was at my home because I had just a back issue. And this mom was so concerned about the bilirubin in their newborn, and they really wanted my opinion. And it took my mom in the background, because I was like, how did you find me? How did the operator, what happened? And my mom's like, they must be really worried, or they wouldn't have gone to that extreme. So that comfort and trust, I think, needs to be there. And still you'll have families that don't agree with what you're recommending, but sometimes it's very acute, and and maybe it's more like we must intervene and they don't want to intervene, the opposite, and just be really this, I'm very scared about what might happen to your child if we don't, do a spinal tap on your infant kind of thing. Is a little bit the opposite, but then just to sit down, talk to the family, and get the chance across the message that you really care about what's happening with their child and that you're listening to them. Yeah. Confirm their feelings, I guess.
Yeah, I mean, I agree. I think that rapport is really special. And I mean, that's something that primary care gets to kind of lean on and really kind of helps a lot when you're talking to patients about, expected management and kind of watchful waiting. And I had a patient that kind of, I think, spans multiple specialties. It was, a younger patient coming in for vaccines, and it was my first time seeing them for a well visit, and they got 3 different vaccines, and then, left, and then had a vasovagal episode in the lobby. And so, everything stopped at that point and went out and kind of made sure that they got the attention they needed and kind of brought them in. And, the staff got them hooked up, and the kid was fine. 2 seconds later, he was awake, answering questions, stuff like that. But, when he went down, he had a little bit of a shaking episode. And so mom was inconsolable, right? I mean, if you're a parent and you see your kid kind of like that, it's hard to kind of watch, not understand what's going on. And so just taking the time to kind of sit with them and be look, he's responding to us appropriately, his vitals are normal, he's going to be fine. He did not have a seizure, and kind of explaining them to him, preventing an ER visit. So and so hopefully they we hope that they have a takeaway from that there's kind of more trust from that too. But I certainly think when your kid experiences that, potentially some more distrust of the medical system too, it can be hard.
Right. That's definitely a time when a lot of explanation is required. Yeah. And on the other hand, sometimes in pediatrics, recognizing how worried the parents are might push you to actually take action, because often the parents are right, as long as you
It's that balance, right? Just very much trusting the parents and what they're saying and listening to them instead of negating it, versus that doing too much kind of thing. And just trying to, sometimes a middle ground. I mean, sometimes there's a middle ground, because you're weighing risk and benefit kind of thing, and other times you just have to be sharper, I think, in terms of what you feel like is okay and not okay to do.
Probably more appropriate in the ER, because you don't already know the parents, whereas she might have a better feel for whether these are anxious parents or not. And right, so same kind of situation. Dr. Patel, thank you.
I was going to share the, I guess, kind of perspective experience that I've encountered, where I've gone into a room with a patient with a newly diagnosed cancer. And, I've kind of gone through the chart, and I was like, well, this is probably a situation where we could, do watchful waiting. And I go in the room, it's just that you can just see the anxiety and just the emotional distress that the patients are in. And when I see that, I'm thinking, oh, this patient's going to want me to immediately say, we're going to do this, and do treatment. And then, when I, do my history and, do what I do, ask my questions, and get as much information from I can with the patient, and then start to present, well, in this situation we can actually do watchful waiting. All of a sudden I see this sigh of relief, and just, oh my, they were, coming into it, their kind of anticipation is, oh my gosh, my life is about to be turned upside down. I'm going to have to go do all these tests. I'm going to have to tell my work, I can't work anymore. And when I tell them, this situation actually, we don't have to do a bone marrow biopsy here. We can, just watch this with labs. I don't think, immediate treatments needed. Like sometimes that, you get the opposite effect, and people just, totally relaxed, and they trust you better. Like, oh yeah, this doctor is not just going to put me on drugs and have me do all these tests. So.
All the more because you did do the thorough history and everything. And so they know that you've taken complete assessment of the situation, and then they will trust what you're going to say. Yeah, that's really important. I'm sorry, I'm speaking softly because I know this is a microphone, but I forget about you guys. I hope you're all okay with hearing us. Okay. Well, at risk of some of these questions sounding a little bit repetitive, so time. We know it can be our friend and it can be our enemy. And certainly in the terms of Dr. Toffel mentioned that, if you have a situation where the patient isn't quite sure, but maybe you have the resource to have the nurse call them the next day or something like that. But maybe in many situations, the question might still be there at this visit. And unfortunately, you don't have the opportunity to book a follow-up visit in a couple of days or a week, because you're booked up 3 months in advance. So that can be a challenge. So I want to sort of have us think about, how does that change anything, or does it? Does time clarify things? Does the lack of a quick follow-up make you more likely to try and do something? Or do you just find a way around that? Or what other sort of risks do you feel are part of that situation when you're trying to make that decision to choose observation or to do something? And then I suppose locking into that or wrapping into that is how to document that you're using time as your tool in a legitimate way.
I'll go first.
Okay.
So for better or for worse, I have the benefit of having my department open 24/7.
Yeah.
So even if I can't see you the next day, one of my partners will. But I think you have to deal with intention. So the other day I saw a patient that had pneumonia and was confused. I said, you have to come in the hospital. You have to be admitted. That's 100% admission.
Right.
And she said, no, I declined. I said, and so what I was able to work around was like, I'll tell you what, you're doing okay now. You have reliable family. Once you come back tomorrow at 8 o'clock, you'll see my partner. We'll make sure you're okay. And so we use that time aspect of things, help declare things. And if any of these things happen, you just come back, because I have the benefit of working in a place that never closes. So I do have that benefit. But I think the system can do a lot better for that too. So the game changer for me in my practice when I started to where I'm at now is that we actually have a clinical decision unit. So we can take patients that we are not sure about, that need some more time in exams, and we can actually put them in the clinical decision unit, which is like a 23-hour quick observation stay, and get some stuff done. And then that actually helps us to actually use time as a diagnostic tool, which is, I think, a great benefit that I didn't have at the beginning of my career.
I'm afraid I am old enough to remember the days when we could admit people for observation.
So I was a hospitalist kind of mid-career. So I started out in practice in rural Tennessee, new and worried all the time, send the infants especially home and worried about them. But I would often call them later in the evening or make sure they were okay. As a hospitalist, I felt much more comfortable, because if I wasn't comfortable with that patient, they were already at the hospital, so they could stay and I could go check on them in the middle of the night kind of thing. So that was really helpful. And then back in practice again, in regular outpatient practice, I think just with more experience, I've gotten more comfortable with things. But yeah, I think that's what I wanted to say. Forget.
Yeah, and I think for primary care, I mean, we have the portal, and so it's a double-edged sword, right? Patients can message us about whatever they want, and they certainly take advantage of that. And
Yeah.
so I have been pretty guilty of like, like I think it's this, but if you're not getting better, like just send me a message. Like if something else happens, like just shoot me a message, let me know too. And so that has been kind of like, a good way to follow up in some situations too, when it's not being abused. But I think too, I really love the portal for like point of care testing too. So I'm like, okay, listen, I know your throat is sore, but you have all these other symptoms. Like, I really don't think it's strep, but like, we'll do this swab and like, you don't need to wait for it. It's going to take 30 minutes. Like, just go home, like do supportive care. And if it's positive, I'll send in something, right? And 99% of the time that it ends up being negative, and then they end up not needing any more treatment. They do go home, do their supportive care for their upper respiratory infection and get better, and then kind of go on with their life too. So leaning on the technology that we have and kind of utilizing that has been helpful too, and kind of letting, the patient can go home, think about it more, they can see their results, and then that kind of like, if the time passes and they feel a little bit better with that then too.
I was just going to add, it's good to have available appointment times the next day for people that you want to follow up. And that's very helpful. It's harder on the weekends. But then telemed has kind of helped a lot of things too, makes it easier to follow up.
Okay, so we are doing great on time. Does anybody have any sort of free thought stuff you'd like to share right now? I do have one more question after this. Okay.
I think for the emergency department, like we have an environment. Oh, sorry. Yeah. We have an environment that is, we have our throughput measures, and we have our patient satisfaction scores, and we have all these other metrics that we're under. And so you could use time different ways. And I think that sometimes we just have to be intentional about it. So like observation as a tool, it's not just the benign neglect. It's actually like, I'm going to intentionally put on your, like the other comment, that I'm going to check on you in 2 hours. I'm not ignoring you.
Right.
I'm going to come back and check on you, but this is intentional. So for me, like the intentionality is the difference between neglect and benign neglect, maybe. So.
Right, intentionality and the documentation of same, right? That's the thing.
I was going to say too, I think a lot of us use like shared decision making now too. And so I usually kind of present the patient like, well, we can do this, or we can also, I think that maybe this is kind of a more benign thing going on, and we could watch and wait and kind of gauge if they're comfortable with that too. And I think, a lot of us kind of utilize that too.
We so going to like ear infections, you can there's a protocol to wait 48 hours with an outright ear infection before starting antibiotics, and kind of along those lines with sharing with the families, like the decision making and giving them options. And often like you can have I'll feel like they don't need to start the antibiotic, but hey, we'll send it to the pharmacy. You can leave it there, or you can pick it up. You can have it if you feel like they're getting much worse, your child, or you're just not comfortable, then you go ahead and use it. But otherwise, don't use it. So that option that the families have in that scenario is often helpful. And I think we have more families that don't use that antibiotic than do when we do that. So.
I was going to say something similar to what you said at the very beginning. Like, you said emergencies often declare themselves with time. And same thing with cancer. Often, patient, I ran this situation today at a young woman in her 40s. She had rectal cancer, underwent surgery, adjuvant chemotherapy, and, guidelines and kind of our protocols, for the first year, we do CT scans every 6 months, for surveillance. And her scan today, she had a new 3 millimeter lung nodule in the right upper lobe, and obviously that brought on a ton of anxiety with her. But talking to her history, I was like, kind of what's been going on? You've been sick recently, and she had a URI a couple weeks prior. So in this situation, I think time will declare itself. I think it's probably post-respiratory nodule. So we collectively said rather than send you to either CT surgeon or pulmonology to try and biopsy this thing, which potentially could easily cause harm. lung, biopsies, often pneumothoraces can occur. We collectively decided, let's give it another 6 to 8 weeks and just, rescan. I mean, if it grows, then certainly, it's much more suspicious that it's cancer, and we would, go down the road of trying to get a biopsy. But, I also explained to her, it is, a recurrence of metastatic cancer. I mean, honestly, learning this earlier versus, 6 weeks later, 8 weeks later isn't going to have, a long-term difference in outcome and how you deal with this.
Okay, I think we've touched on some of these, but let's just wrap up with the recognition of what are the things that pressure you to take action sooner rather than later.
I have another example, just with regard to infants and positional posterior plagiocephaly. I'm having trouble with the word. So basically, babies on their back with the change to having infants sleep supine instead of prone, or having more babies with positional plagiocephaly, so flattening of the back of the head. And sometimes if they're like preference to one side or the other, it'll be on the side or and as well as the back. And I feel like the pressure on these lines is, and it's a little bit political, I guess, but the helmet companies. So the helmet companies come to practices and kind of say, you need this, and these are the measurements, and this measurement, and this, and if you get that ratio, then the baby needs the helmet, and they have to have the helmet, and they're going to have a flat head if they don't have the helmet. And families are aware of this and see this or see other babies with helmets and such like that. So it maybe isn't a bad outcome when a baby has a helmet, but I'm not sure it's a necessary intervention unless they really have synostoses, and synostoses presents differently than just your positional plagiocephaly. So that's difficult, I think, because I've been in a situation where, or lots of situations on babies with flattening of the back of their head, that they all get, they can be really flat and they all curve after a while. And it just takes longer, I think, than it would if you put a baby in a helmet. So, maybe there's not really, it's an expense, and it's a lot of parent sort of, I guess, parent concern or parent worry or parent not wanting their baby to look like that kind of thing. But I think watchful waiting there is very good. And then you don't sort of give that sense of my baby's got something wrong, or baby's got an illness kind of thing from when they're very little. You can just normalize that and know that they're going to have their head will round out. But yeah, I think there's pressure from the helmet companies. And when you ask them for data and stuff, they tell you the data about how the head will round out, but they don't really have the data for why it's needed. So that's my other example.
How many of you get the television told me to ask my doctor about such and such a new drug? Some of them being cancer drugs.
Very frequently. I think Keytruda is constantly on TV, so I get patients ask me about that all the time, probably every day. I get a lot of. Last week I had a patient who had kind of a vague bone marrow biopsy report, and she had a myeloproliferative disorder. And there's different categories of this, and there's kind of gray zones of which one it was. And yeah, definitely she I think she's like 82, but her kids had gone on AI and Chat GPT, and she brought in a list of questions to ask about that. Do I need to do this? Do I need to do that? But this was another situation where her diagnosis was a watchful waiting, and her kids had looked up all kinds of medicines to treat. I'm like, no, that's not, we are not at that level, in your disease state that we need to do that. So we definitely do get that kind of pressure.
I appreciate the tension that as a society, we kind of think that more is more, even when sometimes less is more. And then we have created a system where we're under immense time pressures. Like every one of our practices, like yeah, if you're in primary care, maybe you have 15 minutes to see a patient or 25 minutes. And so we could take the time to sometimes do what we think is right and like spend maybe 15, 20 minutes explaining why we shouldn't do something. We could just order the test. Sometimes it's easy to order the test.
Yeah.
And so we have to kind of that conflict, the tension between doing what's right for the patient, spending extra time sometimes, versus the system that we created that has these immense time pressures.
Yeah, I mean, I really agree with that. I couldn't have said it better myself for that too. I mean, we have a lot of pressures for that. And then we're not graded on like our entire experience with patients, but I mean, we get like a star rating on like every single encounter we have with a patient too in our clinic. And so, you know, I have like one lady that comes in and she's got UTI symptoms and I treat her for it. And she was upset that I treated her for it. She was like, you know, he jumped like too quickly to antibiotics. And I was like, oh, you're having symptoms, you know? And then, yeah, and then there are other people that, you know, they are really looking for that like preventative care, like lifestyle, like functional medicine is in vogue now too. And I think that, you know, a lot of patients really benefit from that too. But yeah, it's hard, especially like going into the weekend too. And so, you know, I'm like, well, you know, you are sick, and if it gets worse over the weekend, then they may need to go to the ER. And so if I'm thinking of preventing a visit for that and you know, intervening then at that point too, there's those time pressures too that are hard too, as we're expected to see more patients. But
I changed practices to my 2-person practice 3 years ago because of time pressures. And so at this practice, kind of sacrificed financially, I guess, but I get to just say how long I want each visit to be. And so they're longer, and that has really helped me, especially sort of later in my career, feel like I just wanted to practice how I wanted to practice. So that's been helpful. Yeah.
Yeah, we all know those Friday afternoon decisions are different, aren't they? So sometimes we feel pressured to take action because maybe we're, you know, trying to cover ourselves, or like you said, time explaining takes too much time, or maybe there isn't another follow-up appointment easily available. I'm going to ask a slightly different sort of question. How much do you think that the level of training of the provider might make a difference on whether they feel action needs to be taken versus having the confidence to do watchful waiting?
I think that there is data that shows that being able to be restrained in how we order our tests, at least from an emergency department standpoint, is based on your experience. So the more experienced of a clinician you are, the more focused you are, not just shotgunning tests. And we see that with new trainees, because there's the uncertainty of the emergency department and we don't have any guardrails, like we don't have to do pre-authorizations, we can order lots of different stuff, but we shouldn't do it. And that's a training experience thing. So it depends which clinician's in front of the patient too. So if you have an experienced clinician, they can be more laser-like focused. They can use their gestalt. If you have a new clinician or someone with less training, they're going to probably order more. That's just the way it is, I think, unfortunately. So I think that really, I think, adds the point that an intentional watchful waiting or focused testing is actually sometimes the best care and really reflects the experience of the clinician.
I had the experience myself coming from Canada in my first primary care job in the States. My first performance evaluation, I lost points because I didn't order enough tests.
Wow.
Go figure.
Not really an outcome, right?
Well, actually, all I said was, "Are my patients worse off?"
Right.
You know? Yeah. Okay. So I think that we have a lot of really great doctors here on this panel today, because I think maybe when we first thought of this topic, that it would be a little bit more novel for people. But in fact, this is actually something we all do every day, right? We make these decisions every day. We don't rush in. I can remember during internship, one of the attendings getting us all to hold up our pen. And then he says, "Okay, you see that pen? Remember how much money you can spend with that pen. Be careful with it." You know, and so we were it was built in to be thoughtful about what you did, right? And so I really enjoyed this discussion. Thank you all so much. You know, the explanation stuff, the things that we do with patients that are part of the process of not ordering a big test or an intervention. are actually the things that do build that trust and rapport and help the patients to understand that we do know how to make these decisions. And that's really reassuring. So thank you all so much. And I don't know if anybody has any kind of last thoughts they want to share, or does anyone in the audience have a question that they'd like to ask? Yes. Would you like to take the mic?
Hi, Brian Camartin, cardiac surgeon. Thank you all for giving that excellent talks. My question is, as I think about my daily practice is when I decide to operate on someone, I get graded on it and outcomes are reported. And so I was wondering if any of y'all could speak to kind of maybe not medical decision making, but whether, outcomes reported things or quality metrics or something that can lead you to decide to do nothing.
So we, for oncology, our practice entered in something. It was a CMS program called the Oncology Care Model, and basically what they were doing was they were, Medicare payments were being. It was a voluntary program that you enter, and practices that entered this, we would get tracked by Medicare. There was certain quality metrics like days on, if some of them were, how many times a patient, was hospitalized. They looked at, days a patient was actually on hospice before they passed away. They looked at time of days on hospice. And they also looked at metrics of, did you administer these patients chemotherapy within a week of them passing away? So these were some, tracked, and, based on the scores, we got, the goal for Medicare was us to, basically, give less treatment over time and only give it when it was appropriate. So that, that was a program where, we actually, did pretty well. We got scores like nationwide. But yeah, that was, definitely something we participated in.
That would lead you to.
So the pressure was to give less treatments and less kind of unnecessary treatment, or if a patient was towards their end of life, like not to give them chemotherapy essentially.
Mm-hmm.
So it was interesting because they gave us scores like before we entered the program and after we entered the program, and our scores got better. Like it was something we got individually in our practice. All our doctors were getting that information of what we were doing, and it did change our practice.
For us as well, similar, like for better or for worse, with the IT systems, health information systems, they can track every click that we do. They can track every time, and so I think that in a good sense, they encourage us to practice almost like a herd immunity. We're always kind of practice the same way, and that goes to testing too as well. So every one of our clinicians is tracked in terms of how many CTUs you order per patient, and then you don't want to be on this side of the standard deviation curve. So that really changes, I think, behavior. And then the other thing is that I think that has happened to our group, and I can see in the future too, is a commercial insurance company said, well, how often are you doing CT scans to look for stones in the emergency department? You should be doing ultrasounds more. Mm-hmm. And if you made this percentage benchmark, then you were a good practice that had more favorable insurance rates. And if you didn't, then we were not. So I can see insurance companies using that as another tool to leverage to try to reduce our, and in some ways, change our practice for better or for worse.
For better.
Yeah, well, and some part of our compensation in primary care is tied to quality outcomes, and so for like mammograms, colon cancer screening, things like that too. And so, in some ways, we're doing that intervention to do the screening and prevent a downstream outcome too, or catch something early. But in one thing that we've done recently that's been implemented is like the ED per 1,000, and so we had to pick some patients that were kind of ED overutilizers, and kind of having them, inviting them to come in for more frequent visits, right? We would see them once a week or once a month or something like that to prevent them from going to the ER and having kind of higher bill there and getting more testing done, potentially there too. And that has kind of changed how we've approached certain patient populations that are utilizing that. And a lot of patients have been really grateful for it. They're like, I appreciate you reaching out for me. I didn't know that I had this opportunity to come in more frequently and just have those discussions there. Then, I feel like I'm out of control sometimes, and there's nowhere else for me to go other than the ER. And so it's nice to, they felt fortunate just to have that kind of safety net to come back to.
So in our practice, we don't have a quality measure kind of thing going on, except for Medicaid and some of the insurances then. And Medicaid follows Medicare a little bit, except for kids, it's a little bit different. I don't think we have as many, they're not looking at as many things as like for adult primary care in terms of checking boxes and making sure you're doing all the preventive stuff. And then for the AAP, you do have to do quality improvement modules for boards, maintaining board certification. So within your practice, kind of looking at things, and you can either design your own project, or you can, look at the AAP website and see what projects they have or have been done. And so there's a certain number of hours, I guess, with that, or points that you have to gain or get every 5 years in terms of quality measures. And sometimes that seems like you're just doing it to get the points, but other times if you really have something that you really want to look at in your practice, it's a good opportunity, so you can make it worthwhile, I think.
So some of those external pressures can improve the practice in terms of not always doing too many, but we all know that insurances and prior auths and things often have the opposite problem, where we want to do something and they try and keep us from doing it. So that's a whole other discussion. Okay, any other questions from the audience? No. Okay, thank you all so much for participating in this panel. We've really been able to reinforce that sometimes doing nothing, well, sort of nothing, is not passive, but in fact deliberate, skilled, and it's often the most patient-centered choice, and it can be very therapeutic. So thank you all again.
So now that the recording's done, we're going to move on to the EPCMS safety and whatnot. First of all, thank you all so much for contributing to this evening. One of the awards and the opportunities that EPCMS has is our Horseshoe Award, and so many